Atherosclerosis. Too much healing going on. I mean, this is the part where we should leave ourselves alone already, because it's that inflammation, our opportunity to attack that cholesterol inside the macrophage, that gets us into trouble. All right, so this is what we're going to be talking about. This is the whole process. So we start with a normal looking blood vessel, nice and clean looking. We move on to a fatty streak, and as you can see, there is a fatty accumulation over time. Some of it gets calcified and forms into a stable plaque. Other is less stable, and as you can see down here, there is plaque rupture. Plaque rupture allows for all of those things inside that inflammatory thing, if you will, get directly exposed into the bloodstream. And when that happens, a clot forms. Because again, you know how when you cut yourself, the body comes to rescue you so you don't bleed to death, right? And it forms a thrombus. Same thing happens inside the blood vessel. And of course, when there's blood supposedly going to a place that it's supposed to be, you're in trouble when there's a blockage there. Does that make sense? So this is all about inflammation, kind of out of control. Again, this is a slide of a normal artery, a little bit of plaque, the plaque rupture, and the eventual clot. This is what we want to stop. This is that inflammatory process. This is a normal artery wall. I want you to see that it's made up of 3 pieces. There's this thing called the adventitia, the media, and the intima. The intima is the innermost part of that cell. That's where the action is in this case. The action is in the intima, but it is assisted by the media and by those muscle cells that actually help stimulate the process of fibrinolysis, and it actually brings some mediators to the reaction. The adventitia is a little less involved. Inside the intima, what we're going to look at is that endothelium. Do you remember me mentioning endothelium? That's that very thin lining of cells, 1 cell thick. It is the security of that blood vessel wall. It stands everybody off, unless of course it's injured. This is the endothelium as a barrier. Really, the cells kind of overlap. They really do protect us from getting the bad guys inside until they don't protect us. And what makes the endothelium not able to protect us? That's what smoking does. Smoking upsets the endothelium. That's what high blood pressure does. It upsets the endothelium. That's why heart attacks always occur where the blood vessels branch out, because there are changes in shear force, and they destroy part of the endothelium. If nothing can get inside, you didn't miss a darn thing. Sorry, I forget my audience. If you can't get inside to cause the inflammation, you can't cause harm. So that's a really important component of this whole thing, to understand the need to maintain that barrier. Really important. And guess what helps to destroy the barrier? Diabetes. Diabetes. How many of you here have collected 24-hour urines from me? In the old days, that's what we used to do. We collected your urine for 24 hours, and among the things we were looking at were the function of your kidney, but we were also looking to see if there was any protein in your urine. The reason that's important, particularly in anyone who's a diabetic, is because if protein leaked through in the kidney, the barrier was broken. And the kidney represented the whole system. It was just like it stood to represent what was going on elsewhere. So if the kidney was broken down, holy crap, the rest of the system might be off too. And what you've noticed is that we've sent off to Cleveland Lab what we call the MACR, the microalbumin creatinine ratio. Now, that's really interesting because you'll get back a normal of 30 or greater. That's what they use for someone with bad kidney disease. If you really want to know what a clean, secure border is, the kind of border we like south of us, if you want that, then you need to know precisely that that protein is almost zero. Actose helps with that border. Januvia helps with that border. So diabetes, nicotine, hypertension, and, are you ready for this one? Low testosterone. Low testosterone can lead to endothelial, we call it endothelial dysfunction. Now here's something really cool. You'll be getting all the new information about the new Z-Life program, and it's very cool actually. Next year it will not only be less expensive and will be easier to do, but among the things that we will have here is we are going to be able to measure your endothelial function. There are probably 100 offices in the country that are doing this. We're getting the machine here and we'll be able to measure it. So you can imagine, for me that's very important because that tells me what success we've really had legitimately at the cornerstone of protection. So if you have a higher LDL but it can't get in, not bad. But if you have a lower LDL but that barrier is open, you're in big trouble. This is that LDL entering the intimal border. What happens as a result of it entering is that you see what this talks about in the media. This is that next layer. These are actually those muscle cells that are starting to send in messages to the intima. Inflammation. So as soon as that LDL crosses that barrier, things start to happen. As soon as that endothelium breaks down, poof, all bets are off. And again, these are those retained lipoproteins that are going to add to that inflammatory reaction. The act of that endothelium causing being injured actually causes that LDL to be oxidized. You heard me talk about that when we talked about that Lp(a) and the ease of oxidation. It's that oxidized molecule that causes a problem. So that's one of the places where medications come into play, blocking oxidation, the oxidation process. But once it gets oxidized, you're in trouble. The endothelium actually promotes oxidation when it gets injured. So again, it's almost promoting a perpetual motion kind of thing. It starts to spiral. Again, we talked about hypertension, diabetes, nicotine, and of course, age. So as we get older, our endothelium is just not as strong as it once was. So age does matter, but if all these other things are under control, Don's going, you bet it matters. Age does matter, but if all these other things are under control, there's no reason why we can't live to a ripe old age and live well. Next slide, please. So as the inflammation begins, all of these cells, and mind you, we actually did mention the muscle cells. So the muscle cells that are coming in from the media, from that underlying layer of that blood vessel wall, actually come to play inside the macrophage. A macrophage is just a great big white blood cell. White blood cells are the inflammatory cells. They are the guys that come to the rescue. The macrophage actually eats the lipoprotein molecule and then creates a foam cell. In so doing, it sets off all of these messages all over the body. Action going on over here, action going on over here, come one, come all, and all the inflammatory cells come. That's the process of inflammation. Just like when you get a cut and it starts to get infected, everybody comes to the rescue. Sometimes you actually see pus. That's a conglomeration of white blood cells, actually thinking that they're healing things. Sometimes they get out of control. So, getting back to where we were, the fatty streak. What's already happened is that endothelium has broken down. The lipoprotein's gotten in. It's caused inflammation, and it causes what we call a fatty streak. Next slide, please. Moving on, the plaque can potentially be unstable. Now, here's what happens. You get this little covering. Do you know how when you have that, when you cut yourself and you've got a little clot on your hand, if you flick it off, it bleeds again because it's unstable at that time. Once it forms a crust, it's much more stable. The fact that we have calcium in those vessels is the crust. Okay? So if you have a big calcified vessel, you don't necessarily have a heart attack. You have old crusty disease, if you will. You may have some angiogenesis because you've built collaterals around it, but it doesn't necessarily mean you're going to have a heart attack. But if the covering over that inflammation is not calcified, if it's not hard as a rock, it can rupture or erode And that's what happens when we have that heart attack. A couple of the enzymes that we measure, among them that we've been measuring, an enzyme called myeloperoxidase. This is an enzyme that has been discovered by the Cleveland Clinic to be a harbinger of you got a problem going on and it's going to happen soon. The higher your myeloperoxidase level, the greater the probability of having a heart attack within the next 6 months. They did studies that on people who went into the hospital complaining of chest pain, and we did all these tests and we said, oh, you're fine, go home. They were dead within 6 months. Why? Because this was going on. But we don't measure that. The usual stuff that we measure is not this. Any patient that goes to the emergency room and from my practice gets a myeloperoxidase level, it's not available for the hospital. We actually have had patients come back here, get their blood drawn, and we send it off ourselves. And I'm very happy to tell you that we've had 2 or 3 patients with high myeloperoxidase levels, and every one of them now are down to normal. But that to me was, whew, talk about a hot flash. I mean, I was on it because it really is a harbinger of a bad thing. It means that plaque is just not stable and you don't have time to wait. This again is the evolving plaque. Now a plaque can evolve and it can become stable, or it can evolve and become unstable. The question is, and the reason is, sometimes genetic, sometimes just the way it is at the time. It can have to do with a lot of things, but genetics does answer to a lot of the problem. You can stabilize the plaque by decreasing the amount of oxidation that's going on out there and allowing the inflammation to cool down. You really want a cold artery. We call it a cold artery. You don't want anything that's hot and bothered. You want it to be cold. Just because you have old disease doesn't mean that you're making new disease. So in some people, we're stuck with some old disease. Our medicines can revert some of that in some people, but you can understand that that's not the primary focus. The primary focus has to be on a blood vessel that's not red hot and raring to go, if you will. Next, please. This is the potential rupture plaque, and the key here is that the outer layer is very fragile. It's very fragile, and it means that there's active inflammation going on and it's just ready to blow. Next. That's the guy that has the heart attack on the golf course. As soon as this stuff gets into the blood vessel itself, it calls for everything to come. Now some people can make that clot, and now you know why you take an aspirin as soon as you have chest pain. What does aspirin do? It makes platelets not work right. What is the primary component of that early clot? Platelets. So that's why we tell everyone with chest pain, take an aspirin, because we can disrupt that clot. We can fling it off. And that's exactly what happens. We also have thrombolytic agents and other agents, but as you can see, timing is of the essence. So God forbid you have a heart attack or you're having chest pain, you go to the emergency room. If you have a clot, we can actually extract the clot in the cath lab, open up that vessel completely. Is that the answer to never having a heart attack? That's the answer to not having a heart attack that day. But clearly, if that process is going on in one place, it's probably going on someplace else. And that's the problem with medicine. Our cardiologists are wonderful people, but they're so involved with extracting the clots and getting rid of the clots and doing the procedures that they don't have the time to sit down and give lectures like this, which is all about making it not happen in the first place. I love this slide because it really tells you, this is like stuff going on. I mean, this is that inflammatory process. This is that foam cell. This is the macrophage. This is the broken endothelium. You can kind of see the action that's going on and the schmutz. I love to call it schmutz. It's a Yiddish word for stuff. But this is the stuff that's going on inside that blood vessel wall. This is the inflammatory process. This is the intima where it's happening, but it interferes with the media as well. And as you'll see, these blood vessels completely restructure over time. And I'll also show you why they're so hard to detect even with angiogram. So once again, good looking blood vessel, plaque buildup, potential clot. Everybody get it? Pretty clear, pretty yucky, huh? Go ahead. As I said, there is all kinds of remodeling that goes on in the blood vessel wall. But what I want you to see here is that if you looked at this and an angiogram, you'd say that blood vessel's open. open for business, no problem, blood flow. And you'd be dead wrong. This is a blood vessel that has negatively reconstructed, and you can actually see it on an angiogram. This one similarly has a lot of disease going on, but you can't see it because the restructuring has happened outside. The intima's gotten thick, the media's gotten thick, the vessel is by no means normal, but the flow looks okay. And what you'll see even more demonstrably next week is that when you do an angiogram on that vessel, it looks fine. It looks like it's open for business. And it is. But what you don't know is that it's got something going on in its wall that could be deadly. We don't have a good means of measuring that except with the intimal thickness, the carotid ultrasound that we did here. If you'll recall, we talked about inflammation because I can see inflammation in that blood vessel wall. That's the new means of modeling. There's a whole bunch of really new interesting contraptions coming up. We'll talk about those at the next lecture. But if you really want to see it, you would have to do an invasive procedure where you actually put a camera inside the blood vessel wall and you can actually see this going on. It's really very cool. Very, very cool. Next. Once again, the vulnerable plaque, you can see blood flow not too bad, no blood flow. I want to get rid of the whole thing. The key here is inflammatory markers are 0. The key here is that blood vessel is cold. It is cold and it's a pipe that's just open for business. Yuck. That's what a clot looks like when it comes out. It's fat.
Yeah.
Is that yuck or what? If that doesn't stimulate you to not eat French fries, nothing will, I suppose.